Now we move forward with this picture perfect moment with the session 5 presidential oration by none other than the president of WBA. Chairperson for this particular session, may I request the presence of Dr. Jyotirmoy Pal and the speaker, Dr. Rajat Shubro Ghosh.
So, may I ask Dr. Shrotish Govind to chair the session, please, since it's a presidential oration from WBA.
Good afternoon, respected chairperson and distinguished colleagues in the audience.
Sir, just a moment, sir. Just before the oration, we have a little bit of felicitation for you.
And we move forward with the felicitation and welcoming of sir.
Good afternoon, respected chairperson and distinguished colleagues in the audience. It's almost lunchtime, and hypoglycemia and HFpEF are not the best of combinations. The diagnostic challenge in the OPD of HFpEF is because these patients are ambulatory and they come in walking with minimal symptoms. And HFpEF rarely occurs in isolation. You see, it is almost always accompanied by associated conditions which are more readily diagnosed. And to diagnose HFpEF, you need greater focus and clarity to distinguish it from mimics and masquerades from which have similar presentations. Now, globally, the percentage of HFpEF patients accounts for more than 50% of all heart failure patients. In India, perhaps the numbers are less, between 19 to 25 patients, but we have a younger population who are having HFpEF in India. Now, is HFpEF a disease or a syndrome? By definition, a syndrome is a recognizable complex of symptoms and physical findings which indicate a specific condition for which a direct cause is not necessarily understood. Now, HFpEF is a clinical syndrome with multiple contributing factors, etiologies, pathophysiological expressions, and thus it is quite a challenge to diagnose HFpEF in the OPD. The hallmark of HFpEF is raised LV filling pressure with normal ejection fraction. Now, according to the universal definition of heart failure, heart failure is a clinical syndrome with current or prior symptoms and or signs caused by structural and or functional cardiac abnormality, and it must fulfill any of the two following conditions: elevated natriuretic peptides or objective evidence of cardiogenic, pulmonary or systemic congestion. Now, today's talk will restrict to stage C, that is symptomatic patients of HFpEF and patients with ejection fraction more than 50%. Now, the symptoms of HFpEF are very common. Usually they have dyspnea on exertion, exercise intolerance, and fatigue. Now, these symptoms are very non-specific. They are seen in the host of other conditions which are seen in elderly obese patients with COPD, obesity, etc. So there is always a potential of misdiagnosis or delayed diagnosis. Signs of heart failure, if present, it's easier to diagnose if we have raised JVP or pedal edema, but the absence of these signs, again, does not exclude HFpEF. And since there is no definite single diagnostic test to diagnose HFpEF, echocardiography alone cannot diagnose HFpEF conclusively, neither can natriuretic peptides. So we need to have many diagnostic inputs for the diagnosis of HFpEF. And the other special tests like exercise diastolic stress test or MRI or right heart catheterization is not easily done for all patients who have symptoms of HFpEF. So as I just said, whereas NT-proBNP levels, which is less than 125, makes it unlikely to be HFpEF, but it does not rule out. Similarly, higher levels does not necessarily conclusively diagnose HFpEF. The main trigger for increasing NP levels is stress on the left ventricle. Now, as opposed to heart failure with reduced ejection fraction, HFpEF patients have a normal LV cavity size, and we know the stress is directly related to the LV diameter. And these patients also have increased wall thickness, and increased wall thickness is inversely proportional to stress. Thus, the NP levels in HFpEF are generally much lower than what we see in HFrEF. In fact, in 20% of cases with proven HFpEF, we don't have elevated NT-proBNP levels. To top it all, most of these patients who are obese, obesity itself lowers the NP levels that we see. Now, HFpEF often occurs in patients with comorbidities like hypertension, diabetes, obesity, renal dysfunction, COPD, and obstructive sleep apnea. So these comorbidities also contribute to symptoms which can overlap with HFpEF. And to top it all, the diagnostic criteria and guidelines, they're also evolving, and there is no universally accepted gold standard. So we need to keep learning, and the algorithms need to be improved as we get forward. So to overcome these challenges, we need to take a thorough patient history. We have to go down to the basics. History taking is important, assessment of symptomatology and a good physical examination, evaluation of comorbidities, a proper comprehensive echocardiography, biomarker analysis, and if all fails, we have to go for exercise stress testing when appropriate. A little bit over the history. I graduated from Kolkata in the year following India's World Cup victory, and that was the year before my alma mater completed 150 years. That was the time in Kolkata we had only 3 echocardiography machines, and it was a new thing. We often had cases with heart failure, which was proven heart failure, and when we saw on the echo, the left ventricular function was normal, and we were quite baffled at that time. So my professor, Professor J.C. Ghosh, he used to say that these are cases of left atrial failure. So I remember the term left atrial failure, and our first president of West Bengal Academy of Echocardiography, Dr. Shankar Mitra, he was a pioneer of echo in Kolkata, and he used to look for the measurements of left atrium and pulmonary vein diameters. So it's interesting that 40 years ago, we were looking at the left atrium. So later on, when Doppler came in, we started looking at E upon A and deceleration times. So the next decade, we got to understand what was diastolic heart failure, what that was called diastolic heart failure. And this issue in Circulation 2002 defined diastolic heart failure as a clinical syndrome characterized by symptoms and signs of heart failure, a preserved ejection fraction, and an abnormal diastolic function. And in 2007, there was a consensus statement, and they termed it heart failure with normal ejection fraction, called HFnEF. And they pretty much said the same thing, and they included mildly abnormal LV systolic function. Finally, in 2012, the ESC guidelines on heart failure, they considered that the diagnosis of HFpEF was indeed difficult, and it was a diagnosis of exclusion. And there are certain characteristics that these patients had. They had a normal heart, they didn't have a dilated heart. They had hypertrophy and increased left atrial size. And most cases had diastolic dysfunction. So we had a working sort of a definition, and but still it wasn't very clear. We had multiple parameters of diastolic dysfunction. Till in 2018, we were given an algorithm which was evidence-based, and it sort of started helping us in the diagnosis of HFpEF. So this was called the H2F PEF scoring system. there was weightage given to certain parameters like atrial fibrillation was given a weightage of 3, and being heavy, that is a BMI of more than 30, was given a weightage of 2, and the rest like hypertension, pulmonary hypertension, elderly, and raised filling pressure was given 1 each. We added up these scores, and when you see it on the scale below, we can corroborate it with the probability of the patient having HFpEF. Now the next year, the Heart Failure Association of ESC came up with another very comprehensive algorithm, the HFA-PEFF score. This has 4 steps. The first step is a clinical step. You assess clinically. It is almost similar to the previous scoring system, the H2F-PEF score. Once we consider that the patient could probably have HFpEF, we go for the next step, the diagnostic workup, which is a comprehensive echocardiographic study along with natriuretic peptides. So I won't go into the details. This is basically the scoring system. There is a functional aspect of the echocardiographic study, the morphological aspect, and then we look at the NT-proBNP depending on whether the patient is in sinus rhythm or in atrial fibrillation. A score of more than 5 seals the diagnosis of HFpEF. A score less than 2 excludes HFpEF, but if it is between 2 and 4, you have to go for other tests like the diastolic stress test and invasive hemodynamic measures. Now, in summary, this is the algorithm for the diagnosis of HFpEF. 1 or more symptoms of HFpEF, more than 50% ejection fraction, and no other apparent cause of symptoms other than HFpEF. We calculate these 2 scores and go ahead. Now, we must be aware of HFpEF mimics. There are cardiac mimics and non-cardiac mimics. Among the cardiac mimics, one must be aware of specific heart muscle diseases, significant valve diseases, constrictive pericarditis, and the non-cardiac mimics are situations where there is volume overloading conditions. So some of the specific heart muscle diseases that are commonly associated with HFpEF are enumerated here: hypertrophic cardiomyopathies and inflammatory cardiomyopathy and the rest. And the volume overloading conditions are common, like anemia, liver disease, kidney disease, lung disease. All these can contribute to volume overloading conditions. So I'll just briefly illustrate a couple of cases which are not classically garden variety cases of HFpEF. All the same, this will illustrate how we use the scoring system. The first case is a 67-year-old gentleman who presented with breathlessness on accustomed exertion for a few weeks, swelling of feet, epigastric discomfort on walking for 5 minutes. He is a non-diabetic, non-hypertensive, non-smoker, history of COPD, and no history of hospitalization. So he had breathlessness and swelling of feet as symptoms. On examination, basically, most of the things were normal except a bipedal edema and bibasal rales and rhonchi. Remember, he had COPD also. So going forward, we did the NT-proBNP, which turned out to be 680. X-ray showed cardiomegaly, and ECG showed LVH with STT abnormalities. So we went ahead with the echocardiogram, and we found that the LV cavity was normal in size. The left atrium was enlarged. There was left ventricular hypertrophy, and there was no regional wall motion abnormality. And on interrogating the mitral valve, we found that the EA ratio was more than 2. E by E prime calculated was, average was 20. The left ventricular ejection fraction was 52 by the biplane method, and left atrial volume index was 64. Even the right ventricular systolic function was diminished, and the IVC was not dilated by the criteria, but it showed less than 50% collapse. The TR gradient came to about 29. So there was a mildly elevated pulmonary systolic pressures. On GLS was reduced. It was minus 8.9. And so when we put it in the algorithms that were before, in the 2016 AAC algorithm for diastolic dysfunction, so 3 out of 4 criteria were positive. So he had diastolic dysfunction, and it was graded 3 diastolic dysfunction. But when we use the H2FPEF score, he only scored 3 which meant a possible diagnosis of about 50% probability of HFpEF. Remember, H2F/PEF score does not have natriuretic peptides. So we went for the second step of HFA-PEF algorithm, and we found there was raised natriuretic peptides, and the echocardiographic criteria added 2 plus 2 points. So 6 points indicated that this gentleman was certainly in HFpEF. So if you notice that the echocardiography showed that the myocardium looked a little hyperechoic, so we sent him for etiological workup with further MRI. So patients with HFpEF with reduced longitudinal strain have a differential diagnosis that include contractile dysfunction, maladaptive hypertrophy, coronary microvascular dysfunction, myocardial fibrosis, and infiltrative cardiomyopathy. The next case was a 59-year-old gentleman who presented with complaints of chest pain, breathlessness on moderate exertion, and noted swelling of feet. He had hypertension, diabetes. He had a diagnosis of HCM. He had obstructive sleep apnea, hypothyroidism, and a history of TIA. His pulse was irregular. He had raised DABP, bipedal edema, and an enlarged tender liver. So his HFpEF score without using the echocardiographic criteria was already 6, which was high. And we did an echo. The primary diagnosis was hypertrophic cardiomyopathy without LVOT obstruction. The left atrium was enlarged, and there was no valvular regurgitation, no wall motion abnormality. And the LA volume was significantly high. It was 89. The IVC was distended. And since there was atrial fibrillation, there were no A waves. So the E by E prime ratio was about 12, and IVRT was less than 65. So, and the TR gradient was 40, which meant significantly raised RV systolic pressure. The right ventricular systolic function was also diminished with RVS prime of 7. The GLS was minus 13.7, so we came to a diagnosis of HFpEF with hypertrophic cardiomyopathy, hypertension, diabetes, hypothyroidism, AF, OSA, obesity, and varicose veins. Now, there are certain difficulties in assessing diastolic dysfunction in patients with atrial fibrillation. There is an absence of A wave, there is a variability of the cycle length, multiple cycles need to be averaged, matched RR intervals need to be used for E upon E prime. And if you have LA enlargement, it does not necessarily mean that you have elevated left ventricular filling pressures. Sometimes AF itself can cause enlargement without elevated LV filling pressures. So we use the top 2 criteria for assessing diastolic dysfunction. We recommended the standard treatment and lifestyle modification that was advised, and went for investigations. The investigations showed that NT-proBNP was significantly high. Now, after echo, his HFpEF score increased to 8, and his HFA-PEF score was 6. So what happens when you don't get a direction after using all these algorithms? If it is neither highly probable or neither low probability of HFpEF, then you have to go in for hemodynamic exercise stress test or exercise stress echo. Now, this is our department in Ramakrishna Mission, and we have the treadmill machine right next to the echo machine, so that when we want to do the post-exercise stress echo, we don't waste time. The patient lies down, and when there is tachycardia, we first look at the wall motion abnormality, and then when the separation of the E and A occurs, we look at E upon E prime and TR gradients. It's quite a challenge. One needs to practice this to do it regularly. Now, apart from the standard algorithms that have been there have been interest in some other parameters. Like in this paper, they mentioned that left atrial minimum volume index was more predictive of cardiovascular outcome than indexed maximum LA volume. And in the same paper, it was mentioned that left atrial functional parameters provide prognostic information independent of LA minimum volume index. Now, this is a very interesting review article by Bianco, Fayed Ghaffar, and Partho Sengupta on myocardial mechanics in patients with normal EF and diastolic dysfunction. And here you will notice that even in stage A, where only the risk factors for heart failure are there, you can get evidence of reduced left ventricular global longitudinal strain, reduced LA reservoir strain, reduced RV free wall strain, while global circumferential strain remained normal till late into stage C. Now, that is why left ventricular ejection fraction remained normal in these patients. So, the recognition of these subtle abnormalities of myocardial mechanics in at-risk individuals can actually help us to start aggressive risk mitigation strategies early on. And it's very important that we diagnose heart failure with preserved ejection fraction so that we can retard the progression of the disease to florid heart failure and hospitalization. Now, left atrial strain has also come in for a lot of interest. Basically, to do left atrial strain, this is how we do it in our lab. You have to grab two good images of the left four-chamber view and the two-chamber view, and then if you have the strain parameters, you can just simply use the strain parameter. It takes about less than a minute to get the strain values. Now, in the sub-study of Paramount study in the HFpEF cohort, it was mentioned that impairment in all phases of LA function and systolic LA strain was decreased independent of LA size. So strain actually gets decreased even before left atrial size increases, or history of AF. And LA dysfunction may be a marker of severity and play a pathological role in HFpEF. And in this paper, in 2020, I think, 22, LA reservoir strain, its time has come. They claim strain has been shown to incrementally predict cardiovascular events, particularly in patients with HFpEF. So finally, when we have diagnosed HFpEF, what do? We confirm the diagnosis of heart failure. Then we treat with decongestant therapy, with diuretics if required. We exclude HFpEF masqueraders and start guideline-directed therapy for HFpEF. In all patients, exercise is recommended. SGLT2 inhibitors are recommended in all patients now. In some subsets of patients, ARNI, ARB, AC inhibitors, and mineralocorticoid receptor antagonists are used. And most importantly, manage cardiac and non-cardiac comorbidities. And this is a very recent article of May 2023, and this summarizes actually very well this paper summarizes the diagnostic aspects of HFpEF and management. So in conclusion, we need a high degree of suspicion in at-risk individuals of HFpEF. Awareness of associated comorbidities is important. Knowledge of mimics that present as HFpEF. Management directed at specific etiologies and comorbidities. Lifestyle interventions is very important, and the new recommendations of drug therapy has to be instituted. Thank you.
Thank you, Dr. Rajat. That was